Welcome to the Society of Academic Emergency Medicine Inflammatix sponsored webinar number 6. Today's topic will be focused on antimicrobial stewardship in the emergency department in the era of COVID-19. I'm Larissa and I'm delighted to present this topic to you. I'm a professor of emergency medicine and direct our emergency department and outpatient antibiotic stewardship program at the University of California, Davis Health, located in Sacramento, California. I do have a couple of disclosures. I have received funding from Inflammatix through my institution to conduct clinical studies as well as speaking honoraria. So first, why antibiotic stewardship? So antibiotic stewardship is really at the intersection of patient safety, public health, and infection prevention. In November 2019, the CDC released a new report that estimates that every year, antibiotic-resistant bacterial and fungal infections cause at least 2,868,700 infections, with almost 36,000 deaths per year. The biggest concern or adverse event related to inappropriate use of antibiotics is the incidence of Clostridium difficile, which causes a significant colitis and recurrent infections in many patients. And we estimate there are over 200,000 of those cases per year, with nearly 13,000 deaths in the United States. Why the emergency department? So we really want to focus here on antibiotic prescribing in the outpatient setting, which is the largest volume of prescriptions that are written. Traditionally, antibiotic stewardship programs have focused on inpatient settings. However, we do know that the vast majority of prescriptions occur in the outpatient setting, particularly for upper respiratory tract infections. And you can see here, while we're not the biggest offenders, we still do prescribe a significant proportion of antibiotics. In fact, it's the second most commonly prescribed medication in the emergency department. So where do we want to be? Antibiotic stewardship is all about optimizing antimicrobial therapy. And so we want to be able to prescribe the optimal antibiotic, which means the right antibiotic at the right dose and for the shortest duration possible to avoid adverse events. In many cases, that means avoiding prescription of antibiotics, particularly for presumed viral infections. There are some major challenges or barriers to implementing antibiotic stewardship in the emergency department and urgent care setting, some of which has to do with the way that we see patients, our overcrowding, our shift-based scheduling format with multiple providers, and having to make quick decisions with limited information, as well as concerns about what happens to the patient when they leave the emergency department and access to care. And many times we end up prescribing antibiotics just in case, because we're not sure that the patient is going to be able to follow up. A few years back, a team that included myself conducted a multi-site exploration of clinical decision-making for antibiotic use in emergency settings. And we surveyed approximately 150 providers in the emergency department, including physicians, nurse practitioners, and physician assistants, on their knowledge, attitudes, and beliefs around prescribing. And we also conducted in-depth interviews with 21 providers across 8 sites in the country. The themes we found that were the most significant were resource and environmental factors. So lack of access to rapid diagnostic tools, not being able to process the number of patients that we were seeing in the department, as well as access and quality of care received outside the emergency department. We know that the ED is a setting where we do see our vulnerable populations and provide a major safety net. Surprisingly, in some ways, the patient-provider relationship or patient satisfaction expectations were also an important driver, particularly of inappropriate prescribing for certain conditions such as upper respiratory conditions. We also found that habit, or as we termed it, clinical inertia, also drives prescribing. So for example, if we've always prescribed vancomycin and pip/tazo for an infection, then we will continue to do that because that's what we learned. Finally, sites that had local knowledge generation, for example, were conducting quality improvement or research outside of the emergency department setting or within the ED, tended to be more willing to reduce inappropriate prescribing. However, we all know that changing behavior is not easy. So changing clinicians' behavior is particularly difficult, and underlining many of these behavior change interventions is an implicit model that suggests that clinicians, when making decisions, are reflective, rational, and deliberate. In reality, under the implicit model, to address a perceived lack of knowledge or guideline awareness, researchers and health system leaders have implemented mainly informational or educational interventions that have had limited success. In contrast, when using a behavioral model, which grew out of the fields of behavioral economics as well as social psychology, this recognized that people, including physicians and other healthcare providers, don't always behave rationally. So how many of us have driven home after a night shift and ended up in a different neighborhood just automatically? So this is what we're talking about. We make decisions that are fast, they're automated, and they're influenced by emotion and social factors. For example, as the day goes on, there's evidence that suggests that our prescribing becomes more inappropriate as we go throughout the day and become fatigued in terms of making many decisions. So a behavioral model will recognize the value of nudges and the influence of social motivation. So what is a nudge? It's changes to the decision-making environment that really, in the case where we're not really feeling strongly about making a decision one way or another, it will nudge us to making the more appropriate decision. So for example, setting a default action in our electronic health record system. Whereas social motivation will take advantage of the fact that we're concerned about what others think of us and that we try to preserve a positive social image. And if you're interested in the topic, there are a number of books that have been written on the subject. For those of you that have read Thinking Fast and Slow, I think it particularly illustrates how we think as emergency physicians. So what are some approaches to stewardship in the emergency department? So we can engage clinicians in existing antimicrobial stewardship programs. These are typically planning committees that are run at the hospital level, but provide an opportunity for multidisciplinary collaboration with our infectious diseases specialists, with administrators, with the laboratory and pharmacy. Education is also important, however, has limited utility in maintaining our efforts. Finally, initiating or implementing guidelines and clinical pathways, particularly when combined with clinical decision support, can be useful. And some of the most success we've had based on this behavioral model I talked about is peer comparison and other nudges that help guide us to make the right decision. Finally, one area that continues to accelerate rapidly is the availability of rapid and point of care diagnostics in the emergency department. And finally, a lot of antibiotic stewardship efforts will focus on outpatients or care transitions. There is a huge opportunity in our patients that are discharged out of the emergency department, whereas hospital antibiotic stewardship programs are typically focused on those patients that are being admitted through the emergency department, for example, patients with sepsis. We're fortunate in the ED that we do have some very unique facilitators. We're typically used to working in teams and applying team-based approaches, and most emergency care providers tend to be willing to take on new tasks and learn. That's particularly true for those of us who are in academic settings, but is also true in many community settings as well. We can take advantage of patient education and communication tools, and we really do provide the nexus between the hospital and the community. And then many of us like to innovate and create. So we can implement local guidelines and pathways, use clinical decision support, implement the opportunity to have rapid diagnostics, as well as make use of local antibiograms to design empiric or local guidelines. What are some targets for stewardship? So a few years back, as part of an effort with the CDC and an outpatient antibiotic stewardship working group, we came up with some strategies for how one might implement stewardship in the emergency department. And so some of this was the use of appropriate antibiotics, meaning antibiotic selection. So this could be for community-acquired pneumonia, urinary tract infections, which also requires having an appropriate diagnosis, as well as miscellaneous bacterial infections, such as skin and soft tissue infections. There is a whole category of conditions for which antibiotics are not necessarily needed. And there's great evidence, for example, in acute bronchitis, that antibiotics do not improve outcomes. And so these are the presumed viral infections or antibiotic non-responsive conditions. There are a couple of categories in here where antibiotics are sometimes appropriate, such as for acute sinusitis or for suppurative otitis media that require a little bit more nuanced guidelines. Finally, there's an opportunity to improve diagnostic testing, particularly for bacterial infections, and some of the HEDIS measures do focus on the appropriate treatment of strep pharyngitis with antibiotics only with implementation of a rapid test. And finally, there are a whole host of other conditions for which we prescribe antibiotics, which we could think about how to reduce antibiotics to the lowest level of prescribing. So typically, in terms of the United States, there's more prescribing that's going on in the Southeast, whereas the West has less prescribing. So our goal might be to try to normalize or reduce prescribing in regions that have higher rates of prescriptions. So I've been talking about antibiotic stewardship a lot. Well, what about COVID-19? What does this have to do with COVID-19, and how has COVID-19 impacted our prescribing strategies? So I'm going to start with a case vignette. We have a 52-year-old African-American male. He's got a history of diabetes on metformin and hypertension on lisinopril. And he presents to your ED with 2 to 3 days of pleuritic chest pain and a cough that's mostly dry, but occasionally produces white phlegm. He's also having some headaches and body aches. His only history is he recently traveled to visit his daughter in Los Angeles, which is a high area of community spread for us in California, and a brief episode of near syncope while he was standing in line at the post office. In terms of his review of systems, the only other thing that's noted is he's having some nausea, but no diarrhea or vomiting. His temp is 38.2, his heart rate's in the upper 90s. He seems to be satting pretty well at 96%, a little bit hypertensive. And then on exam, he looks pretty dehydrated. You're getting some scattered bronchi on his lung exam. And really, his labs are unremarkable except for his elevated glucose, and he has a low sodium. You do send, thinking that this patient needs to be admitted, a D-dimer, which is elevated, as well as an ESR and CRP, and fibrinogen are also all elevated, which may indicate he's at risk for progression. His EKG is normal, but his chest x-ray does show some bilateral diffuse opacities. Because of the elevated D-dimer, you send a CT, which is negative for PE, but confirms ground glass opacities in his lungs. And finally, because you have access to a rapid point of care test for the SARS-CoV-2 virus, that comes back positive. So you end up admitting the patient for observation because he seems sort of borderline, his vitals are stable, but how to treat him? Should we give him antibiotics or should we withhold antibiotics? What about steroids? I won't really address the steroids component here, but just thinking about the things that we typically do for patients that are admitted with what we consider mild to moderate COVID infection. So how do we optimize antibiotic stewardship in the ED during the COVID-19 era? Well, we have some traditional approaches. For example, we can provide education to our physicians and nurse practitioners and physician assistants. We can implement care pathways and guidelines, which many institutions have done. Or if we have significant outlying prescribing practices, we can do some individual education, which we call academic detailing. And then there's a whole other category of opportunities, such as implementation within our guidelines of host response biomarkers, as well as rapid COVID-19 diagnostics, for example, the point of care test that I made. I want to just focus a little bit on the very limited literature that we have looking at co-infection or superinfection. So this was a systematic review published in Clinical Microbiology and Infection fairly recently, looking at a living rapid review and meta-analysis of bacterial co-infection and secondary infection, as well as antibiotic prescribing. This is the table 1 that comes out of the study. So you can see there were quite a variety of studies that were included, obviously all very recent. Most of them were in the intensive care unit or impacted adults. Some were done in children, but these are all inpatients, obviously. So bacterial co-infection in this group of studies, including the meta-analysis, was pretty uncommon. So 3.5% of patients, but ranging from 0 to 45% of patients had a bacterial co-infection, meaning along with SARS-CoV-2, they were also found or detected to have a secondary bacterial organism that was present at the same time. And then I should say secondary bacterial infection, so that's infection after the initial illness occurred in 14.3% of patients. So therefore the overall proportion was pretty low at 6.9%, but not completely insignificant. They did find that infection with a bacterium, in addition to the SARS-CoV-2 virus, was more common in patients that were critically ill. And the majority of patients with COVID-19 in this particular set received antibiotics. So 72% of patients received antibiotics, which is not unexpected since we're dealing with inpatient ICU settings. The challenges or limitations of this study is that a variety of methods were used to detect the bacterial infections, and these were not consistent across all the studies. There have been a few other experiences that have been published. For example, there was a South Korean experience with a nationwide cohort. So they looked at 6,800 patients that had COVID-19 and found that 35% of them received antibiotics, so slightly less than the other study I just presented, and 8% of them did, however, receive broad spectrum antibiotics in terms of anti-pseudomonal agents, or they did receive anti-MRSA agents, and that was more common in severe illness. And the most common antibiotics that were given were fluoroquinolones, third generation cephalosporins, and macrolides. They, in these studies, could not actually confirm that there was a bacterial co-infection, and so there's a lot of concern for potential collateral damage from adverse events or increasing drug resistance using these broad spectrum agents. Similar findings were found in a study in Spain that basically compared antibiotic use in March 2020 compared to February 2020. So 11.5% increase in antibiotics. And then if they went back and they compared the use of azithromycin in particular compared to the prior year in January and found that that had increased 320%. They also found increased use of non-respiratory broad spectrum antibiotics. So this is obviously concerning in terms of our antibiotic stewardship practices, particularly with the use of azithromycin, which tends to be an indicator of, of treatment of community-acquired pneumonia, but also of overuse, particularly for viral respiratory tract infections. So are there current recommendations for how to manage COVID-19? This was produced by the NICE organization in the UK and basically suggests that empiric antibiotics should be started if there's clinical suspicion of bacterial infection, and to use existing community-acquired pneumonia guidance unless the patient's been hospitalized for more than 48 hours. So for our setting, we would be following our CAP guidance. They do recommend that a microbiological evaluation is sent. So in this case, looking for lower respiratory tract infection, such as a sputum culture. And first line should be doxycycline plus amoxicillin, or a fluoroquinolone can be an alternative if there are contraindications. They also recommend using the local antibiogram to guide therapy and also the shortest duration possible. There was also a Dutch working group that published some recommendations in Clinical Microbiology and Infection recently and state that there's limited evidence that supports restrictive antibiotic use upon admission. They also recommend obtaining sputum, blood culture, and bacterial identification studies for de-escalation in the inpatient setting, and to limit duration of antimicrobial therapy as long as the patient's improving to 5 days. Unfortunately, we have not yet seen guidelines or guidance from the Infectious Disease Society of America or SHEA or the Emergency Medicine Societies. There are a variety of recommendations in terms of antivirals. However, they remain mum for the moment on antimicrobial use. In general, though, the standard of care, particularly for patients that are sick enough to get to the ICU, is to overtreat, not undertreat. So what are some diagnostic strategies moving forward in this era of COVID-19? So the first is we now have a variety of tests that are approved under emergency use authorization for identification of SARS-CoV-2, also working on identification of other tests, such as SARS-CoV-2 plus flu plus RSV under EUA. But what's missing is the ability to distinguish between any viral and or bacterial respiratory tract infection that might guide antimicrobial therapy. So this may be a role for host response technologies in the future. So to summarize, antibiotic stewardship is important in the ED, as in other outpatient and inpatient settings. There has been some guidelines that's been developed and implemented successfully, but because of all the challenges of not having rapid diagnostic information or guidelines at our fingertips, we know that antimicrobial stewardship is going to be difficult during the COVID pandemic, and that most clinicians are erring on the side of antibiotic prescribing, and that we really are going to need to monitor whether we have more adverse events or we're actually contributing to antimicrobial resistance, particularly if we're using non-first line agents. We also need better diagnostics to distinguish viral from bacterial infections, and those tests should ideally allow us to detect co-infections as well. So the future is better guidance, pathogen identification, and inclusion of host response when those technologies become available. And you can find out more at inflammatix.com and on our next webinar.